rural areas. My name is Deirdre Assay, and I'm a senior policy analyst at the Council of State Governments Justice Center, and I'll be moderating today's session. Today, we'll be hearing about the work being done in Yavapai County, Arizona. We are joined by Beya Thayer and her colleagues from Yavapai. I just want to mention that today's session is funded under the Justice and Mental Health Collaboration Program, or JMHCP. We want to thank BJA for their continued support of improving police responses to people with behavioral health needs. And I want to note that we are recording this session, and a recording should be available by early next week. I will now turn it over to Beya.
Good morning and good afternoon, everybody. Thank you, Deirdre and Ethan and Carly, for inviting us to come speak with you all today. This is pretty exciting. My name is Beya Thayer. I am the Executive Director of the Yavapai Justice and Mental Health Coalition. And the coalition is a project under the Yavapai County Sheriff's Office, but it is a true countywide coordinated response to working on the intersections between the criminal justice world and the behavioral health world in crisis. And so we have a lot of great team players and stakeholders and leaders that are part of the coalition, and we have smaller work groups, and we're really working towards utilizing the sequential intercept model that is our community needs assessment, and looking at where our strengths are and where the gaps are and everything in between to create those processes. And a lot of our work is done on intercepts 0, 1, and 2. So building the behavioral health and social service providers, agencies that we have available, and then of course providing the tools for people to recognize when there is a behavioral health crisis, especially for law enforcement, and also at the jail if people do get arrested, and then what are some of those tools that we can utilize to get individuals into the services that they need rather than into the justice system. So today with us is Paige Lafort. Paige is with Spectrum Healthcare, and she's going to talk a lot about their mobile crisis system and how that got put into place. Tamara Player is with Polara Health. They have our crisis stabilization unit and tons of other services as well. They both do. And then Commander Brent Kimbrell is with Yavapai County Sheriff's Office. In Yavapai County, we are in pretty much kind of dead center in Arizona, just a little bit north of Phoenix. Geographically, we're the size of New Jersey, the entire state of New Jersey, with just 250,000 people covering that entire area. We have a mountain range that goes through the middle of the county, and we don't have any vast transportation, like public transportation that takes you from one side of the county to the other, but we share a lot of resources, or we need to share, of course, a lot of resources. Our state's crisis system is funded through our state Medicaid system. So the state Medicaid system provides the funding to our behavioral health providers, and it's for years been based off of a fee-for-service model, not like a general like firehouse model, right? To make sure that somebody's always there, ready to go 24/7, get there as soon as possible, regardless of how many fires you're going to have. So our state has historically funded mobile crisis and crisis on this per call, which has not, of course, been very advantageous for law enforcement to be able to pull people from the corners of our counties from all over the place to ensure that mobile crisis is coming to meet law enforcement as soon as possible. So as our behavioral health providers were building their robust system, there had always been kind of some holes and gaps because of the geographical makeup of our community, and trying to understand and trying to fund and get trained and have people on board and ready to respond as soon as possible to lots of different locations. And the commander and Paige can talk about some of those characteristics of what some of these locations look like. We also historically had a barrier with having a central location for crisis stabilization for a drop-off for law enforcement. Again, there was a whole funding piece involved. And so Polara was able to work with our Medicaid health plan and with the partners and design a crisis stabilization unit that fit the community's needs and work alongside law enforcement and what that could look like, again, to try to make it quicker for law enforcement to utilize crisis services than to utilize the jail or our local hospitals. And so we have it set up. We have some talking points that we want to kind of tell you our story today of how we got to where we're at. The good, the bad, the ugly, the lots of discussions and talking in between, and where we're headed to in the future. And then of course, there's definitely room for lots of questions as well to hear from you all. And so I hope that we're able to provide some really great stories and encouragement as you guys build your crisis responses as well, because we're definitely in a place where saying no or making it, this is not possible, could have easily just been the mantra. But we're a team full of let's find the yeses, and here we are today. So I was wanting to ask the commander to provide some kind of backstories, and some of these might sound really familiar for your jurisdiction as well, but some of the catalyst stories of how we were able to, what crisis response looked like for law enforcement before we had some of these great services in place. And then we'll kind of move into how we were able to build from there.
Thanks, Beya. Hello to everyone. I'm Commander Brent Kimbrell, Yavapai County Sheriff's Office. My career has mostly been in patrol, search and rescue, and SWAT. And for approximately 2 years now, I've been over in detention, getting exposure to that side, or this side, I should say, of the field. Little historical, we're 8,128 square miles, like Beya said, so we are a very large geographic county, and we are divided by many different types of terrain. It can go anywhere down from Sonoran Desert up into pines, into mountainous regions, and then we have rural communities within some of those regions as well. We have ones at the top, like Crown King of the mountain, and we have ones all the way out in Baghdad, Arizona, which is a mining town. So we cover the gamut of rural area. We have 27 fire districts. So we deal with a lot of partners and 11 municipalities for law enforcement. So it's a very, we have a lot of players and stakeholders involved. The pre-crisis, what we used to do in the old times, I call it, and I think, thank God we've progressed a lot. When we had some sort of mental health issue, we were always trained, we ask, we tell, and we make. And that usually resulted in us having use of force incidents or aggravation to any of the response that we had when somebody was in crisis, which would sometimes we would create our own jeopardy or preclusion where an instance would happen that they ended up hurting themselves, creating damage and things like that, which resulted in their arrest, which is very unfortunate when we're supposed to be out there trying to help somebody. But because of our training, which is good in some circumstances, a lot of times it isn't conducive to somebody who has a mental health issue. So one story in particular, as I was talking with Beya, this was what kind of kicked off, or the final straw, maybe put it that way. I had just promoted to sergeant, and it was around 2014. And literally my first 10 minutes on the job as sergeant in promotion, we had a call for service. And I was working a grave shift, and it was for a suicidal male on top of a bridge with a knife to his throat. And I didn't have any CIT training, crisis intervention training, any of that. I was a deputy on the road, SWAT guy, and search and rescue. So, you know, I had a different view of the world. And he was threatening suicide, and nobody was piping up on the call to get services or get him help. So I went through and I looked through. We have a CAD screen that shows what deputies are on duty at the time. There was no other sergeants or anybody else available. I being 10 minutes into my new position, I found 2 negotiators that assisted with the SWAT team for us in negotiations for, you know, all kinds of different situations, barricade subject, but they were 2 guys who could talk. So I immediately had them. They were in the area, which was on the eastern side of our county. I sent them over immediately to start negotiating with the gentleman with a knife to his throat and a bridge above a freeway. So as they were attempting negotiation, we were trying to get fire resources to respond to the scene as well, to be able to help. Unfortunately, if, you know, something drastic happened, or to be able to get some sort of hospital services at the time. We didn't have, you know, the mental health services in the same way that we do now. And as I was heading that direction, had about 45 minutes of driving code to get there. On the way, 2 cars caught on fire on that same freeway with occupants inside. So fire diverted all their resources to that incident that was about 10 miles away from where the subject was on the bridge. So that right there, we didn't have the ability to have any kind of medical service to the individual. The negotiators did end up talking him down from committing suicide. And then once they were able to get the knife from him, they ended up deciding to do their own transport to the hospital, is what they were going to do. And they put the subject in the car, and while they discussed strategy, they're briefing me on the incident. The subject ended up started bashing his head inside on the cage, tried kicking out the windows, dented the inside of the car. And so that prompted the deputies in that time is, oh, now we have criminal damage. And so the subject now ends up getting arrested, and now he's going to be booked. So what we did there is, instead of having another resource like the advent of mobile crisis, that situation in particular was reviewed, and by the current sheriff he's the current sheriff now, but at the time he was a jail commander, the same position I have. And it prompted him to look at what was going on and why this person who had a mental health issue, they were suicidal, it was not criminal, could go from that point all the way to now being arrested and having damage and also having injury. And so that's what the advent of this whole mobile crisis into getting together with the third-party mental health providers. And basically that's kind of how it all started. So that was a nice journey of walking away from where we used to just take somebody with mental health issue and take them to another county or put them in another jurisdiction. All the law enforcement were doing those things at the time, and about a year or two after that, that started coming to a screeching halt, and we had a resource.
Well, and at that time, was working for the Medicaid health plan, and I was so excited to be able to come down to Yavapai County and tell some of the various law enforcement agencies that this crisis stabilization unit was going to be built over in the Prescott Valley area. And they said, well, wait a second, think about how big our county is. And they told me this story, which at that point, Spectrum Healthcare, which that story occurred in Spectrum's jurisdiction, and they had just gotten a new CEO. So I went back and started calling the CEO saying, hey, it looks like some other services are needed. And so we were able to start collaborating with law enforcement to try to bring up what would have been helpful in that scenario and how to move forward. But before Paige starts describing that, I wanted Tamara to start also kind of talking about what was happening in her side of the county and what it took to get the CSU up and running, and how you collaborated on that piece.
Yeah, absolutely. Thank you, Beya. And it's hard to follow your story, Brent, but I'll do my best. So, just there were so many circumstances in our community that really highlighted a need for us to do something different, right? The example that Brent gave is just one of dozens of stories. And so actually, before I joined the organization, the former CEO of the organization did a fabulous job of really sitting with community partners and pulling together groups to work on designing a crisis stabilization unit to meet the community's needs. So our crisis stabilization unit, we deal with walk-ins, police drop-offs, and then referrals from anybody in the community. Our number one referral is really people just walking into our crisis stabilization unit. It's available 24/7. We have 10 chairs, observation chairs, where people can stay up to 24 hours. We have 8 beds, and then we have a crisis therapist who can do an assessment, do some safety planning, and get someone connected to outpatient care, just depending on what they need. When we were designing it, one group that was really important for us to bring to the table was our law enforcement, right? They are out there all the time dealing with these situations, harm coming to individuals and the officers in our community. And again, a recognition by our community that it needs to be different. So we said, what do you need? What do you need in order to make it easier for you to bring people with who are experiencing a mental health or substance use crisis to us than to book them in the jail? And they said, we need an easy way to drop people off. And so based on their feedback, while we have a front door that most people walk into, for our law enforcement agencies, we have a side door. And they can bring them right in. We have paramedics on staff. So our goal is to have police officers back on the street within 5 minutes. And we have consistently met or exceeded that target until this past year when we started court ordered evaluation. And I'll talk about that a little bit later. But through this partnership, right, we were able to say, what does our community need? How do we meet those needs? How do we design a facility in a way that makes it really easy for our law enforcement agencies to get people to the right door? And then from there, we just really continued that partnership with law enforcement, regularly meeting with them, talking about what's working and what's not working. And that created a foundation for us, again, as we took on the court-ordered evaluation this past year. But I don't want to get into that now. I'll wait till we get to that point. One of the things that was absolutely critically important is a really strong relationship with our mobile crisis teams and organizations. And again, working directly with Spectrum now, who's the mobile crisis provider, has been, I think, key to our success, as well as working directly with the law enforcement agencies. So I'm going to start there. Beya, did I capture everything that you wanted or something else?
Yeah, thank you so much.
Sure.
So remember how we described we're physically the size of New Jersey, with a mountain range going down through the mountain or through the middle of the county. And it was kind of the way that our behavioral health system was split up when all of this was occurring. So this is back 2014-ish, 2015-ish. It was still, we had large behavioral health home providers, and they were designated to a certain area in the county. And Tamara's crisis stabilization unit was actually about 45 to 60-minute drive away from where this other crisis occurred that the commander was describing. And that part of the county was designated to Spectrum Healthcare. So as the CSU was getting built and the payer source, right, always follow the money, was just going to do one in our county, what were we going to do for the other side of the county? And then that's when Spectrum came to the table, and Yavapai County Sheriff's Office says, okay, I will get all of our providers or all of our agencies, the police agencies in this area, to come to a discussion if Spectrum, you want to come and hear what they needed, and if you really think that there's something that you can be able to do to meet those needs. And so I'll let Paige talk about how that got started.
Absolutely. So my name is Paige Lafort. I'm the Director of Crisis Operations for Spectrum Healthcare. And following the incident that the commander talked about, our agency was one of the agencies approached in deploying mobile crisis services. And what was really important to us as we developed a community-based mobile crisis team was meeting the needs of rural communities. And in order to do that, we really focused on, okay, officers need someone there in 30 minutes or less. We need a place for an individual to go if a higher level of care is indicated, and we need community-based resources if they are safe to stay at home. And how can we deploy all of this 24/7 in a county the size of New Jersey? And we rose to the occasion along with different agencies over the past 10 years. And what is a priority to us is what we call geolocation. So we hire individuals to work in our crisis team in the most remote areas of our county. So that way we have somebody in the far reaches that's available quickly. And we also just partner very closely with our law enforcement agencies, and we're having constant communication and feedback on how calls are going, how response times are going, what the community needs. We would not be able to have the programs that we do today if it wasn't for the interdisciplinary collaboration between law enforcement, CSUs, the coalition, the crisis teams, constantly seeking to evaluate the needs of the community and how to best meet those. Our team's goal in every single call is to maintain safety in the home and in the community. So we focus on providing access to resources to help stabilize someone in their home environment. And when we're not able to do that, then we utilize facilities like Polara to help get them into care at a quick time, 24/7, without overutilizing emergency rooms or hospitals.
So what I saw that was really, really beneficial, because our law enforcement friends, you guys have memories that go back to 1986. And so I would hear constantly, well, I called them way back in 1986 and they didn't respond then. And so we're not going to try them again. Does that sound familiar? I see Jeff Brinkley kind of nodding his head like, yeah, that might sound a little familiar. So Spectrum, in setting up this mobile response, we started meeting weekly with the partners. And every week, each call would kind of get dissected. And I think the partners on the eastern side of the county that were involved, there was probably 6 different agencies. There's even a tribal land that's here. We have one town that probably only has 1 patrol person on, and it's a mining town on the top of the mountain. And then we have where the jail's at as well. So it completely varied, but there was weekly meetings at the beginning. And I remember a lot of the conversations of, hey, we really don't get that many suicidal calls. And so Paige, can you talk about that mobile crisis and how it was able to grow into understanding that this isn't just a suicidal call, and what that took to try to educate and change the culture for law enforcement to understand all the various calls that they could call you or bring folks over to the CSU for?
Sure. So what we really looked at was what was causing a lot of these low-level arrests, what was being brought into our jail, what were the officers seeing? And what we found is a really big emphasis on social determinants of health. And the more we talked about these calls and the more we looked at what was coming in through our 911 call centers, anybody that had a social underlying issue could easily be referred to a crisis team or worked with a crisis team rather than just an officer. Sometimes people call 911 because they don't know who else to call. And the more involved we started getting on these calls and the more conversations we started having about these calls, we were really able to broaden the scope of what is considered crisis intervention. It is not solely isolated to suicidal subjects. It is substance abuse. It is homelessness. It is family conflict and family fights. It is domestic issues. It is evictions. I mean, it's adolescents not going to school. It's everything that you can think of where is the real problem here a crime, or is the real problem here an underlying issue that needs support to move through. And that allowed us to start being called more and more. As soon as officers knew, we would take those civil matters. And as soon as officers knew that, hey, I don't have to drive this person to jail today, I can get them over to the crisis team, our call volume started increasing exponentially. And that's where a lot of our work lies throughout all of our trainings is look at the need underneath what the 911 call was initially for, and does that really need a police officer intervening to address a crime? Or is there a social issue going on that can be best handled by mental health professionals in collaboration with the justice system?
And what partners and stakeholders love to see is data. And these two agencies do a great job of presenting data, of showing mobile crisis would be able to speak and say, hey, we asked the officers, if we didn't come, where would you have taken this individual? So they could show this many folks could have gone to the emergency department and this many folks could have gone to jail. And here's what we're seeing when we're going out on calls, like what different substance uses are, what the different crises are. And Pilar tracks who's bringing these folks to us as well. Like who's our major game players, which law enforcement agencies are bringing individuals to us. And again, what would happen if you didn't bring folks to us, where would they go? And I will have to say that in 1 year's time, our bookings into our jail drastically dropped. So remember, we're a small county, so we were getting about 9,000 folks arrested every year. And in 1 year's time, between these two entities setting up, about 1,000 people, the bookings were about 1,000 less. And when we pulled the data, it just magically was almost identical to how many referrals the crisis stabilization unit was getting from law enforcement and how many calls that Spectrum Mobile Crisis was responding to for law enforcement. So it was working. Commander Kimbrell, can you speak to how the Sheriff's Office sought out funding to be able to train not just Yavapai County Sheriff's Office, but all 12 of our agencies around the county in identifying individuals with behavioral health needs?
Sure. We had reached out and for a grant from the Bureau of Justice Assistance in order to get funding initially to start for our mental health first aid trainings. And so the concept is instead of just getting a grant that is only going to benefit our agency, why not have one that benefits all of the municipalities and the agencies that are involved in Yavapai County? So the thought process, the very beginning, was to include everybody in this training. And that ended up developing into our crisis intervention training. And that is a training that we do with municipalities twice a year on both sides of this mountain that goes through Yavapai County. But we have an eastern and a western side to Yavapai County. And so twice a year, we have these trainings with the local law enforcement agencies and with our partners in behavioral health, like Spectrum, for example, the VA, they come out as well. We also have different people with different skill set for like autism, somebody who has a specialty in identifying autism, the spectrum of it, and things like bipolar. So these are great partners for us. And we did this collaboration with Prescott Police Department originally. And so we could have law enforcement talking to law enforcement. So we speak the same language. And at the same time, we're introducing these other resources so that law enforcement gets used to seeing them when they actually go out into the field or when there is a crisis that occurs. And we started building those relationships. So it's kind of like breaking down the silos between this is us and this is them. You're civilians, we're paramilitary law enforcement. We're trying to and have done away with that kind of thought process where we're all partners together and trying to help somebody in a time of need and not elevate or have the arrests occur like they were in the past. This crisis intervention training has been so influential and mobile crisis. We spoke a little bit. I gave you the story on patrol. we come from, but also on search and rescue and SWAT. So I was the sergeant in charge of search and rescue for the county for 5 years, and then also the commander for it. And then also on SWAT, I was an operator, the team leader, and the team commander for 11 years. And so just with autism, let's say as an example alone, for having a search and rescue, we used to, in search and rescue, we would go out and we would throw all kinds of resources at it, whether it be a mounted horse unit, dog units, quad units, ground pounders, walking on foot, helicopters. But what we were doing is we were using whistles, lights, sirens, attention getters, and we were actually causing somebody who had autism, that was a juvenile or even an adult, we were actually pushing them away, and they would actually shelter down even tighter. And we were giving up a lot of time in actual search and rescue with being able to help that person, sometimes even a day. Fortunately, we were able to save many of the people who had autism, who had gotten lost in this vast county. But it also had to do with this crisis intervention training, helping with law enforcement in the tactical realm. So when we have somebody, it's a great thing when a SWAT team's called out, when you have, for example, a barricaded subject in the house and something's occurred, whether it had been a domestic violence issue or an alleged, or somebody's having a massive mental breakdown, but there's a safety to the community that's being considered. And a tactical team comes out. In the older days, what would happen is we would implement through a series of tactics. We would use things in order to get that person to come outside so that we could detain them and then do whatever we needed to, which in the past usually resulted in arrest. But how great is it if I can have mobile crisis come out there, and if they can tell me that this subject inside actually has schizophrenia and is hearing multiple voices, where I would use my tactics before, whether it be gassing inside a house to trying to get somebody out. All I'm doing is putting another irritant inside on somebody who's going through a mental crisis breakdown. They could also let me know when we're having negotiators negotiating whether or not that person was on their meds, because that's probably why they're having the mental breakdown and the crisis, because they don't have a driver's license, because they have schizophrenia. And when they can't go and get their medication, they're not taking it. And then sometimes a breakdown occurs. So as a tactical team, it was super beneficial to us to be able to know these things, because I could just get medicine sometimes out to the situation and go ahead and have a resolution. And this will sound kind of interesting. I'll make it quick, but I did go to a training through the National Tactical Officers Association. But I had some big players up in Washington, D.C. and Oregon on their tactical teams, and they had gone to what's called explosive breaching. And I thought, oh, that's great. Explosive breaching, as a breacher myself, it's a great tool we can use a lot. And they said, no, Brent, this is not for your ego. We actually use this is because when we have somebody that has a mental health crisis that we have a lot of times we go out on, we used to just go in and we throw gas in. And those people would have a further breakdown and sometimes even result in suicide. So what we do is we use the explosive breaching. We're able to place a charge on a door. It's a low explosive charge. And we can go ahead and open that door and just do a temporary stimulus to that subject, and then renegotiate or interact with them again. Or we can create what we call a communication portal. If they're barricaded up and I need to put a hole in the wall, I can use that charge, put a hole in the wall, and then start talking to them again, or be able to get past medication through, or pass a throw phone through, where before we would just gas the house completely, not knowing this person had a mental health issue. And it just made things worse for that person as well as the team, and how we were having to deal with the situation. So having mobile crisis, these other bigger players talking to us about crisis intervention and some of the tools is really changing law enforcement and how we go about with these situations and contexts.
Yavapai County Sheriff's Office also received a grant from SAMHSA for mental health awareness training. And one of the goals of this grant was to get a cadre of law enforcement officers trained as trainers in mental health first aid on the first responder model. And like we said, we have multiple agencies. This was to go out and get as many folks from different agencies trained as trainers so that it can continue way past the time of the grant. And that also added a huge shift. Just that 8-hour mental health first aid training is a reminder of the things that Brent was talking about. And then knowing that, hey, you're not out here identifying somebody by yourself. We also have these other tools available, such as our crisis partners. Through another grant funding, Yavapai County Sheriff's Office created a cross-system database. So we have 5 dispatch PSAP agencies across the county, and then the 12, including DPS, I think, and the tribe law enforcement agencies. And there's nothing connecting any of these folks to speak to each other or collect any of the same data. So we've created this database, and you can get to it from the cloud. And we have trained our PSAP partners to be able to get into the database. And what we have done is ask, hey, if a law enforcement agent did some kind of deflection for a community member, whether it just be to hand them a flyer with a crisis number on it, or take them to the crisis stabilization unit, or take them to have mobile crisis come out, or do civil commitment, anything that was behavioral health related and the person did not get booked into jail, if we can please just enter that information onto this database. So it would say Prescott Police Department had a disorderly conduct for Beya Thayer and took Beya Thayer to the crisis stabilization unit. That's it. No HIPAA, nothing else going on. But then a week later, when Prescott Valley Police Department comes across Beya and they're saying, I think there might be something going on with this individual, they can call up and ask dispatch, can you look to see if there's anything in the database related to Beya Thayer? And oh, look at that, they went to Polara's crisis stabilization unit a week ago. Hopefully that kind of triggers a, let's get her back over into Polara Health's hands, and instead of booking the person into jail. If that person does get booked into jail, then our inmate service coordinators at the jail have access to say, oh, this person's received services from Polara. We're going to make sure that Polara knows that their person is here to help coordinate care. That database, of course, ebbs and flows. It's only as good as people put the information in, but it is there, and it's one of the tools that we're able to use to support, to definitely support community members and trying to deflect them out of the justice system and into the service provider's hands. So one of the most frustrating pieces of crisis is the civil commitment process. And I know that's frustrating across the nation, no matter what state or county you're in or what it kind of looks like, because it's a really difficult, very difficult time for the person involved. And of course, difficult for the community members and the first responders who are dealing with this person who is in an acute scenario and not wanting to get the assistance that could help them get stabilized and get back integrated into the community. In Arizona, we call that the Title 36 process, because in Arizona statutes, it's under Title 36. And our counties are actually responsible that there is a civil commitment process set up. And the counties then contract out with providers in order to complete what's the required screening and evaluation process. And we now have Polara Health doing this process. It's been just over a year that they've taken this contract and have had to utilize the crisis stabilization unit for this service. And Tamara is going to kind of talk about what that looks like, since it's definitely always first responders that are involved in trying to collaborate with the crisis system, and what it looks like here in rural Yavapai and lessons learned.
Thanks, Beya. It has been quite a year, as you can imagine, and you work with this all the time and know the level of vulnerability and hurting that's going on in your community. And we certainly have the same piece here. Prior to taking on the court-ordered evaluation process, our county was really struggling. We had what I would call lots of silos and lots of barriers to doing what was needed to help that individual. Those barriers then created a tremendous amount of frustration for our hospitals, law enforcement, us as providers, that we had these people cycling through our care that weren't always getting the treatment that they needed. So when we were awarded the contract for the court-ordered evaluation, one of the first things we did is, I think, a strength of our community, and that is we pulled all the groups together to say, let's talk about what do we want the system to look like, and how do we create the system that we need as providers in the system, as well as that the individual and the family needs to provide care. That led to several community conversations with the sheriff's office, law enforcement, Spectrum Mobile Crisis, the hospitals, and again, really working to design a system that gets people where they need to be. So one of our strengths, based on the feedback, has been we find a way to say yes. And as a result of that, even if someone comes in on a title and becomes voluntary, which in Arizona, if they say they're going to become voluntary, they can. We have been able to serve all the individuals who were appropriate to come in under a title, even if they decided to become voluntary. In the past, those individuals were turned away and essentially said, here, you go get services some other place. We're getting them into our crisis stabilization unit, starting them on medications, and then getting them connected to care, really helping to prevent that people cycling through the system repeatedly. That has certainly helped our law enforcement agencies and decrease frustration there, but also for our hospital partners, where we'd end up with individuals with behavioral health crisis really backing up the emergency rooms. So as we were designing, we worked with Spectrum, and just full transparency, Spectrum is a collaborative competitor to Plara, right? So if you're running into those turf issues in your community, I will say we're an example of an organization that has found ways to make that work, focused on the larger values and goals for our community. And it's been a wonderful partnership. I think Paige is on the phone on a regular basis with our Title 36 lead, really working through issues. So we've done a really great job, I think, attending to 90% of the people accessing this care. And through the Mental Health Coalition, we talk about who are those 10% that we still need to find solutions for our community. So individuals with dementia, for example, the law prevents us from going through the court-ordered evaluation, court-ordered treatment process. So what are those solutions? So Beya, Paige, and I participate in another work group working to solve issues around dementia in our community. We're looking at individuals who their primary need is substance use, but when they're using substances, they become suicidal. And so they get titled. And, we're seeing some recycling of people through our system with those needs. So what do we do there? Oftentimes it means having a conversation about one individual who is really complex, and how do we get to a yes and work as a community to get to that yes. And through that, we have lots of learnings and then apply that to a similar situation in the future. But it's really been, and I think Paige articulated this well, it's really been because of the collaboration across sectors and a willingness of leaders to say, we are going to work to a yes in our community, that we have seen pretty significant turnaround for our court-ordered evaluation process. And after the first year, we're looking at our data and saying, where do we need to do better the second year as we go into it? So, but really thankful for the partnerships and the success that we've had in serving the needs.
Thank you, Tamara. Tamara made a great point. We are no longer siloed in Yavapai and in Arizona based off of geographic locations for our behavioral health providers to serve. And so, yes, Spectrum Healthcare and Polara Health, they overlap in locations geographically and folks that they serve. And some people might be a Spectrum client and they end up in Tamara's crisis stabilization unit. And we have other providers as well that are all part of this collaboration. So Paige, I'm going to jump back over to you to talk about how mobile crisis has grown as you've grown across the county, and what you've been working on with the dispatch centers and with the agencies to respond, not to wait until you get called out at the scene, how that's morphed into co-response, and then the future that we're looking at for actual 911 deflection as well.
Yeah, absolutely. So as we built confidence in our mobile crisis response with law enforcement over the last, goodness, 8 years at this point, 6 years, somewhere in there, almost a decade, we started realizing that a lot of these calls as we were getting there, that the officer wasn't the best party to arrive first. And so we started challenging ourselves and asking questions on how we could get there even faster, how we could provide services even quicker, and how are we dispatching the most appropriate resource to every call that comes in. And what that led us to discussing was the first evolution of our goals for the next several years is what we call a co-response model. And that is where any call where a mental health issue is identified as a component that reaches the 911 PSAP, we get sent at the same time officers do. And we call that our co-response model. So rather than an officer arriving on scene first, talking with everybody, getting an idea of what's going on, then requesting a crisis team, 30 minutes later, the crisis team arrives, then we can start doing intervention. We wanted to shorten that down. And so what our PSAPs do now is we help train our dispatchers on screening and identifying mental health issues. And as soon as they flag that, they call the mobile crisis team at the same time and deploy them in tandem. So we are arriving at the same time. That is reducing the time officers are spending on scene and reducing delays in service provision. As we build confidence in that, the ultimate goal is a full 911 deflection program. And what that will look like is we will be screening 911 calls in the 911 PSAP with a crisis worker in the 911 PSAP and dispatching directly to mental health professionals when there is no crime being committed or no crime involved. And that is a full deflection into the mental health system where we can avoid officers entirely. As Beya mentioned, we have multiple PSAPs. We have an extensive number of agencies involved in our county. So each one has its own unique needs and demands at this time. So that's one of the things that makes our county interesting is how do we make a universal process fit 14 different chiefs and 14 different agencies and 14 different needs. And we are working in very strong collaboration with other systems of care to make this happen. So we see that as our long-term goal. I would say that's our 5-year plan. That's something Beya and I have been working very hard on over the last year and a half on how we can help make sure there's infrastructure and training and screening and triage to make sure that these calls are handled appropriately. Who's doing this well? Who can we model our program after? And how can we be successful in rolling this out? And again, that just keeps going with the continued collaboration with our law enforcement partners and also a new interest from our EMS providers. So we're starting to talk a lot to the fire services and to the ambulance providers because they're going on these calls as well. And so looping in all of our system of emergency care to include a mental health first responder in that dynamic.
Tracy had a great question, but before we get to that, I know that we only get Tamara for just a few more minutes. Brent and Paige and I will be on until 5:30 the next hour, wherever time it is in your time zone. And so we'll swing back to the safety training for that, for the mental health, the mobile crisis responders, because that is a very great question. But I want to make sure that if anybody has questions for Tamara around the crisis stabilization unit or the civil commitment process and trying to get all of that together, what kind of data that she collects, if you guys can use the time right now, maybe to address some questions for Tamara, and then we'll circle back to the mobile crisis.
Thank you, Beya. I'll also put my email address in the chat. So if anybody has questions afterwards, I'm happy to respond to any email or support you any way we can.
Thank you. Just a reminder, folks, you are able to unmute yourself, so you can actually just come off mute and ask your questions outright or type them in the chat and I'll try to read them out loud.
Sure.
Tamara,
there's some
Brian
questions.
Cook has a really good question. I think that's a great one to address. It says, any issues of under census or over census at the CSU that you have had to figure out?
Oh, yes, both. Certainly under census during COVID, the pandemic, that impacted us some, and needing to reduce. So our chairs is one big room with 10 chairs. And when we had COVID, we obviously needed to make that safe. And so that impacted us. The over census, I will say, since we've taken on the quarterly evaluation process, we're constantly triaging, and we work closely with Spectrum and the hospitals to say, where can we kind of, I'll call it, stack people up until we have a bed. We prioritize law enforcement referrals because if they're in a hospital, somebody's safe. If they're not, then we need to get them into the unit. How it has impacted us in terms of over census is we haven't been able to serve as many walk-ins as we historically have. And we use our emergency rooms but in a different way. I will say they're partners. They know that we're going to get them out as quickly as possible. And it's just a different feel and a different conversation based on the way that we're working. In the short term, the county actually has built this beautiful new facility for us called the Connection Center. And so we'll be adding an additional 12 beds in our community. And that one will be primarily for the Title 36 population, but we will still take walk-ins and work with the law enforcement because it's in a different community than our current crisis stabilization unit is. So it's been a lots of really good and important conversations that have helped us get through the, I will say, over census issue.
Tamara, you mentioned a quarterly evaluation process and or ongoing meetings between law enforcement and staff. Could you explain that a little bit more?
Sure. So before we have a meeting with our community partners, which is a standing meeting that we offer hybrid. So we have a meeting room, but also people can join by Zoom. We look at our data to really understand, even before we go in that meeting, what the potential issues are that could get raised. And we usually go into that meeting, one, to hear from our community partners about any experience that they have that is highlighting that, our system needs to continue to improve, or to share with them things that we're noticing, right? So I think it was, early this year, we noticed we had one individual that was cycling through our systems. And so being able to talk about that as a community in a de-identified way to say, what are we going to do and how are we going to do this differently? Which in this situation, we said, look, we're going to title this person the next time they come in because it just isn't working what we're trying to do. But it creates an opportunity for us to consistently meet and talk on the systems level. We are really fortunate that we have built collaboration. So if there's an immediate need, people pick up the phone and call each other. And that's what makes it work in the moment. But then you also have to stop and reflect on what's the systems issue. And those quarterly meetings give us that opportunity to do it. The quarterly meetings include our law enforcement, the hospitals, Spectrum as our mobile crisis. We have 2 other behavioral health organizations that attend periodically, and then we facilitate that meeting. There was another really good question about, do officers have to call? No, they do not. If someone's coming from the jail, the jail regularly will call us, or the sheriff's office will call us, but it is not a requirement for them to call us to triage. That's our job, to take them in and do that evaluation and that assessment and then get them where they need to be. The police officers just need to be able to say, someone doesn't look right. And I don't think this is a jail issue, right? This is a mental health substance use issue. And then we'll do the evaluations. If we're not able to place them in our crisis stabilization unit because of capacity, because we're full, we will work to get them to another hospital or crisis stabilization unit.
Do the officers need to know that though prior to showing up at your door? Or you do it both ways?
Um, do they need to know if we're at capacity, Beya?
Correct.
No, they don't. Because again, it's 24/7. We have crisis therapists there that can engage with the individual. We try to make it as simple as possible for our law enforcement agencies. You know, they're in the middle of dealing with crises. They need to get back on the streets and to policing in our community. And so they just can bring them, drop them off. Sometimes we're able to stabilize them and do safety plan and they go home. Other times they come into our facility or we'll get them to another facility. But the police officers don't need to worry about that. That's our job to take care of that for them.
And it looks like one more is specific to you if you have the 1 more minute, Tamara. It says, does the CSU utilize internal staff for all escalated situations inside the CSU for an already admitted individual, or do you rely on law enforcement at all?
We try to use all of our staff first, but we do call law enforcement when it's needed. And we did see initially when we started the court-ordered evaluation, an increase in calling the law enforcement agency to help us out. And so that's why we ended up extending past our 5 minutes. We asked our law enforcement agencies if it's a title person or someone they're bringing in for a court-ordered evaluation, that they stay a little bit longer and to help us evaluate what's going on for that individual. Because if somebody's really dysregulated, aggressive, psychotic, we can give them a shot, give them an injection right at that time. And we ask the law enforcement agencies to help us with that. Otherwise, we really try, we use, unfortunately, we do have restraints and our staff are all trained in seclusion and restraint. And so we'll try to do that first. We have providers on 20 or not 24/7, but they're on 7 days a week. And then we have on call as well. And so we'll use our medical providers and use medication as a way to also help us to prevent having to call police. We really only call them when we really need them. And I think that that's helped as well. So if we've called them and they felt like we didn't need them, we had that conversation, right? And we'd go back and we would train our staff or talk to our staff about what happened. So they know when we call, it's because we need them and they are there. It's been a great partnership.
Thank you, Tamara, for joining us. I think that I can probably help out with some of the questions in here about the partnerships and the conversations occurring. And then Tamara's email address is in the chat if you guys want to email her directly.
Thank you for the opportunity. Have a great day.
Thank you. Paige, there's a few local crisis ones. Do you want to jump in? Okay.
Yeah, absolutely. So there's a question in here on how we ensure the safety of our mental health workers. The biggest thing is training. So we partner very closely with our law enforcement agencies. So we receive quarterly trainings from our law enforcement partners on scene safety and awareness, drug recognition, violent recognition, escape techniques. I wouldn't say defensive tactics because we are not aggressors or we don't have the physical component, but they're trained in self-defense methods that are also approved by a mental health curriculum. So that way they do have a means of protecting themselves or someone else should they choose to. Their training includes going on ride along with different police departments prior to their go live date, have heavy focus on screening, triage, and assessment before deploying a mental health worker. So it comes from a lot of different areas. And one of the things that I think benefits rural service provision so much is we know where we're going. We know what street address we need to avoid. We know the names of the individuals that are higher risk than others. We all have a very close sense of communication with each other. So my dispatcher can say, hey, this meets all the criteria for your screening, but last week we had a call on this road and this happened. I'm not comfortable with you guys going out alone. I'm going to send this as a co-response. And if it wasn't for those relationships and that constant communication, we could miss some areas. And then just the awareness that we can't prevent everything. So we are always seeking ways to advance our training opportunities, but training is going to be the foundation of how we keep everyone safe, and also slow rollout of programs. You know, we need to build trust and build efficacy before we dive into the deep end.
Paige, did you also partner with law enforcement to get radios for when you're out in areas that the cell phones don't work?
Yeah, so that's been a discussion for rural areas, especially areas where there's no cell phone service, is how do we get direct access to dispatch? So some other areas we've employed is GPS tracking of the vehicles. So that way we have location, real-time location at all times. There is conversation about us getting radios. The problem with that for our county is we have 4 PSAPs, some are digital, some are analog, and how do we have a radio that accesses all of it? So we're working on that. We also have an app that our fires guys use, Active 911. So we're looking at, could we possibly be on that app? So we're looking at direct methods of communication into the 911 center directly, especially as we go live with 911 deflection fully.
And then do you want to jump into the staffing question?
Yes.
Sufficient staff to ensure a consistent, quick response. Whew.
Yes, staffing is an issue. I will not even beat around the bush. I'm hopeful it's not just an us problem. I don't think it's just an us problem, but staffing is very hard. And one of the things that makes that a challenge for us is the credentialing requirements that mobile teams have to have per our Medicaid contract. So they have to be what's called behavioral health technicians, which requires a certain level of education or experience before entering into our field and finding qualified candidates that are willing to work shift work and jump into that first responder-esque field. It's a unique individual, and so they are hard to find. But what we do find is a really good retention and longevity of our crisis workers. So we do our best to recruit the way that everyone is doing right now. One of the endeavors we're working on right now is creating a crisis training academy. So similar to how you would have a detention academy or a police academy, seeing if we can bring in people with arguably no experience or background, run them through a training academy through our agency and a couple others that are partnering with us, and then certifying them as crisis response specialists at the end of that academy rather than requiring a 4-year degree. And we're currently actually receiving a grant for that and working with our Medicaid system on preparing something to see if this would work. So just being creative in recruitment as well.
So Spectrum Healthcare went to Yavapai College, which is our local community college here as well, and said, hey, we need behavioral health techs. And in working with the college, they started up an entire behavioral health certification program at the college. And so they've been able to pull in professionals to help teach that. They already had folks on staff that already were able to teach it, but it's kind of a way of thinking outside the box of if we don't have the people who have gone through the schooling and we don't have a university, most of you guys do have community colleges. So work with your local community colleges to create classes to give you the professionals that you need. I thought that was brilliant and it's heavily utilized. Brent, there's a question about fentanyl and opioid overdose crisis in the rural areas, and maybe it'd be great to get law enforcement's point of view and then Paige jumping in as well.
Yeah, absolutely. So we have a narcotics task force that we have that's out there. And the task force that's out there has detectives that come from each municipality if they want to contribute to that task force, which most do. But the task force isn't only to just try and remove the fentanyl off of the streets, which that's a major part. It's also to help get information and intelligence that we can help prevent overdoses or overdose deaths. So we have overdose death investigators that are part of the team. Their sole job on the task force is to investigate overdose deaths and to find out where and how that got in to that family's community or that household and an overdose occurred. But then it's also super important for us. We can look at where the overdose fatalities occur, and we have a heat map that we have access to, and we can dispense or supply naloxone or Narcan to those areas to try and help. So all of our deputies and just about everybody in the county, municipality-wise for law enforcement, including the detention, carries Narcan or naloxone. Just 2 nights ago, a female, she overdosed, and they had to do 10 doses of Narcan on the female, and also use CPR, which then ended up actually working. So they were on the scene and start dosing and assessing, and then doing CPR. Medical professionals get there, take over, and you know, she's doing a lot better. But that's what we do. So it's not only narcotics task force. We do hammer the quantities. And as you know, Phoenix and Arizona we are the largest in the United States for trafficking of fentanyl, by 10 times at least. And that's due to a lot of different issues, but there is a crisis out there. And so we want to not only be able to take the drugs off the street, we want to be able to get the resources to save lives, and then they can get the addiction counseling. We definitely see a difference in Yavapai County between the dealer and a user. And we always try and make sure that we're conscious of that, so that we're not equating the two, so that we can get, you know, definitely help for those people. And then the predators, we deal with them in other ways.
Yeah, and in conjunction with what the commander is saying, it is that partnership as well with our mobile teams. So whenever we see a hotspot on that map, we're getting calls from deputies saying, hey, here's something we're seeing. Are you guys seeing this too? And we can almost track it par for par, how many detox requests I'm getting and how many new stops we're seeing on the law enforcement side. Our mobile teams also carry Narcan. Also, anybody that is deemed at risk for an opiate use disorder is left with Narcan from any mobile team call. So we also distribute while we are out in the community. One thing that I also feel like we should mention is the intense focus on diversion that we have in Beya. I don't know if you want to talk about that from your side as well, but what I see is officers, they've identified this isn't the dealer, this is a user, they need help, they don't need to go to jail. And so even though they're out there, they're calling a mental health team and saying, hey, this person needs rehab, this person needs residential treatment, or if they do have to go to jail, the jail is working for release to treatment to Polara and Tamara's facility and different collaborations like that. So that way we're addressing the whole individual and not just, oh, here's somebody who used fentanyl or here's somebody who overdosed on fentanyl. Let's prevent this from happening again. And so you have to see it as a system of care from every angle, not just one point of contact.
Yeah, we've built up a few different areas in which people can enter into different forms of diversion. So everybody getting booked into the jail has opportunity to meet with an inmate service coordinator that screens them for different risks and social determinants of health, or any services that they might want upon release, to start thinking about that immediately, because of course the jail's population is very fluid. We don't know how long somebody's going to be in here. So there's a lot of individuals who come in on a probation petition to enact. So they've gotten into trouble. A lot of it has to do with substance use. And the court system has gotten very used to the fact that we have these coordinators now available in jail who can work with the courts and then work with our providers on the outside that have residential treatment. And people are offered an early release to treatment at their sentencing. So, hey, you know, Beya, you've got served 90 days or you can get out early into residential treatment. And so we work really hard from within the jail with Polara and Spectrum and other providers as well, and with the courts to get those folks out and into treatment. And those individuals actually recidivate and come back to jail at the lowest level of all of our different populations. We have our county attorney's office does the diversion program that's allowed through statute, and then they can hold back on charges if the person is successful through that diversion program as well. We have a substance use coalition in Yavapai County that has created an opioid review board. And they go through and look at as many of the overdose, it's an overdose fatality review board, sorry. And they look at all of the overdoses that resulted in a fatality that did not look like it was a suicide throughout a calendar year. And of course, what we've noticed through that is the multiple drug use as well, right? So fentanyl popping up in different places like meth or different substances as well, which is pretty difficult to address and to work with. There was a question that I received from Michael Harper about breaking down those silos, and who Tamara had mentioned having partners at the table to talk about what those different silos are and who are those partners. And usually it starts with the people who have direct contact with the population that we are focusing on. So not to speak for Tamara, but in most scenarios that would mean that she sat down with the emergency rooms, with law enforcement agencies, with the crisis responders, with our other behavioral health providers, and saying, when you're seeing these folks coming into crisis and needing to discuss or look at involuntary evaluation, then what's occurring at each of those steps where that person is coming into contact with you, and what is it that you need support with. And when you talk with different disciplines, what I've noticed over the last few years in my position is that, of course, there's a lot of feelings involved, right? I wholeheartedly believe every single one of us has the same goal at the end of the day, right? To have a healthy and safe community. We just all get there in very different places or different ways. And one of the means that makes it kind of easy to break down some of these difficult conversations is data. And we've mentioned that a few times throughout this webinar, is what's the data that you guys can bring to the table? So is that how many calls does law enforcement, did they go out on that they felt they didn't need to take that person to jail on? Or how many calls, when Paige brings in, this is how many people that we responded to in these different jurisdictions. Any kind of data, how many people are in the jail that are on psychotropic medications? How many people were in the emergency room only waiting for further placement? And that has been successful in trying to take some of the feelings out between the different disciplines and have constructive conversation of, okay, then where is it that I can step in to help you with some of those numbers? So I hope that helps a little bit in the conversation questions. There was another one about
There was one that was, I think it got a little lost, but there was a follow-up on the census question that's also related to staffing. Asking, has it been hard to manage staffing for the mobile team, needing sufficient staff to ensure a consistent, quick response, but not having mobile workers with excess downtime is a hard balance to achieve, I would think.
I think
I had answered that. Is there something that we need additional clarification on, or that I can talk a little bit more about?
Sorry, I just wanted to scroll back and make sure that
You're
there
good.
weren't any that were missed. Thank you.
Couple that I see. So Jeff asked, do we have regularly scheduled meetings for high utilizers? Yes. So the biggest thing there is obviously making sure that you are following HIPAA guidelines and protecting the privacy, especially 42 CFR, for any substance abuse issues. The way we navigate that with our law enforcement entities is through MOUs that allow us to communicate, and confidentiality agreements, and then interagency as well. So Spectrum Healthcare and Polara, we have a business associate agreement that allows us to communicate on mutual clients. So just ensuring you're protecting privacy. But yeah, we meet monthly, if not more often, when they really come on the radar. We're meeting consistently. Let's see.
Michael had a funding question as well, if you want to unmute and ask that.
So thank you. So I work for the court system in Pennsylvania. So the Supreme Court has an initiative, as do some other states, to try to get conversations going. And our biggest priority is crisis infrastructure and deflection and diversion. And I've been here 5 months and I see the landscape. It's very challenging to move it. Every agency is going like, go over there or go over there. So we're really close to corralling everybody and unsiloing. So that's the next conversation we have to have. But right now, I think, two sticky points is the state rolled out brick and mortar funding, but then said it's up to the counties to have sustained funding. And they don't think that the medical assistance model is going to be enough. So I'm waiting to meet with SAMHSA because I know they have the bigger picture. But in the meantime, is there a state-county partnership with the funding? Like, it seems to me it would make more sense if counties that can afford it would maybe come up with some. But basically, we have this money to build crisis infrastructure, but no counties took it because they're like, we don't have the money. So we're just kind of stuck there. And we're already 5 or 6 years behind other states. So I'm ready to move it. I really got to move it. So what's the secret sauce?
I'll try, Beya, and then I may need your help too. So a couple different perspectives. So yes, we do have county money and we have state money. Tamara would be able to talk to you about county money because that's who funds the involuntary commitment process. For us, we've only been Medicaid funded for crisis intervention since October of last year. So the entire 7 years before that, we ran at a deficit to get this need to our community to prove a point that it needed to be funded. And we proved the point and we got the money afterwards. Now I realize that that's not always achievable in circumstances. So we've also received grants from multiple different areas. So we've had grants from Blue Cross Blue Shield, different grants from SAMHSA to be able to deploy these services. And then also looking at our follow-up model. So one thing we looked at is enrollment statuses and where individuals are seeking care. Is this getting other places and just through cost savings? So if an individual sees a mobile crisis team in the community and it avoids an ER visit, how much money are we saving by not having that ER visit? Okay, now the hospital is going to agree to pay a certain dollar amount for this many avoided ER visits. So looking for getting creative with your funding sources is going to be huge because there is always seed money, but continued money is always the conversation. So really being creative, we diversified our income model extensively for mobile crisis operations. And like I said, we didn't receive that big lump sum Medicaid payment until October of last year. And we started this in 2016. So we had to get very creative with funding. I know there's also a very big push nationwide to get private insurance payments on crisis services. So we're also heavily involved in that discussion. Our CEO is, and seeing parity in that service.
So when you say you went through the rigmarole for 6 or 7 years and
Yeah.
you got Medicaid funding,
Yeah.
that was to build a case
Yeah.
for Medicaid to say yes.
Yeah.
So,
Yeah. So Medicaid had always funded crisis, but the dollars amount varied, the service provision varied. Beya, I think, is probably best to answer this because she has that background. Did you have?
Yes, so the way in Arizona, of course, the federal Medicaid dollars come into our state Medicaid office, but our crisis services are actually paid for out of our state legislature budget to help cover. So the state then uses some of their general funds, gives it to our state Medicaid office to fund out crisis. And it's always on a per call basis. So that whole brick and mortar piece, in order for Tamara to build that crisis stabilization unit, was very tricky to do so. Most of the billing is for each call, and our Medicaid health plan did not provide Spectrum that contract in order to bill them for years until they just kept on doing it. And finally the Medicaid health plan said, okay, we'll take some of the state funding and we'll be able to bill you back. But at the same time, a lot of it is just per call and not, like I was saying, the firehouse model that you're always going to be there. It's definitely one of the trickiest pieces. But we do have the ability now where all the crisis calls that they go out on, they can bill for back to Medicaid, no matter what a person's insurance, if they have Medicaid or not. Like crisis is just covered across the board for everybody.
All right,
But
I'm going to go
without
plan
knowing
B.
Pennsylvania's setup, it's kind of hard.
Yeah, it is. All right, Thanks. That's very helpful. Thank you.
Yeah.
Beya, there's a question here about your database. I'd like to learn more about the PSAP database that includes the name of the individual and assistant service carried out. Is an ROI needed to be shared with EMS, mobile team, fire, and PD?
No, because we're not giving any really protected health information. So it's just stating that this person, there was a deflection for this individual. So it doesn't give you a diagnosis. It doesn't tell you what happened at the end. It doesn't give any information if the person, the subject was handed off to Paige's mobile crisis team. It doesn't say what happened after that whatsoever, whether Paige and her team took the person and stabilized them in the community, or took them to the hospital, or took them to the CSU. None of that information is there. It's pretty much just the information that here's this subject, this individual, and here's what the original call was, and here's how law enforcement ended the call. We gave her a referral, or we handed her to Paige, and then we walked away. So there's no real medical information that's going back and forth at all. It doesn't say that the person enrolls with Spectrum Healthcare. It's just, I handed them to Spectrum and I walked away. And I could send, if you put your email in the chat, like I can send some screenshots on it. It's very basic. If I had it pulled up, I would share it. There's questions about client choices regarding not wanting medication or sedation in the stabilization centers versus pressure to not call police or ambulance back. Is there potential for over-titling individuals in these centers?
I don't want to speak for Tamara. That would have been a great question for her. What I will say is, for our system of care in Yavapai County, we're probably overly cautious with our Title 36 and involuntary commitment process. We will always err on the side of client right, and not going through that COE process. So I don't think we have a problem here over titling individuals in these centers. I think we almost pendulum swing the other way, and we have to almost build a case to get somebody enacted on a COE. But as far as medication and sedation in the center, that would be a great question to email Tamara on.
And then Paige, do you see the next one about if a degree is needed?
Yes. So credentialing of mobile crisis teams. So for Arizona, the BHT certification is either a 4-year degree or equivalent experience. One thing we do to expand the definition of equivalent experience is it doesn't have to be a strict behavioral health setting. A lot of the people on my team are former EMTs and paramedics, former ER nurses, former detention officers, former police officers. If they come from a first responder field, we use that as an equivalent to behavioral health experience, especially given what we do. As far as therapist on call, so what we do not send licensed therapists on crisis calls. It is all BHTs, but they have a licensed therapist available by phone 24/7, and they have to staff every call they go on with a licensed professional prior to leaving the scene or creating a disposition. So they are always they're never making a decision in a vacuum, and they are always working with a licensed individual on every single call and on every single decision that is made. We also use peer supports. So each of our 25% of our teams are peer supports. So that has also been monumental in the service delivery, because they can come out to these calls at a different perspective than a crisis worker or a therapist. And we found that to be really beneficial as well. So we use a combination of peers, BHTs, and licensed providers.
Eddie, is your follow-up question about opioids? Are you saying that law enforcement cannot administer Narcan? You said the challenge is finding clinics in rural areas that could administer the medications for OUD. Or are you talking about like other medication assisted?
I was mentioning more. What I wanted to know was more those that are dealing with opioid use disorder. How do y'all deal with those in treatment where there's not much clinics or there's not too many clinics that will provide that medication?
Are you talking about Narcan or like methadone and Suboxone?
Methadones and, yeah, methadone.
So what we look at here is our referral process into those treatments. So for a period of time, our emergency room had the SOARS ORS funding where from SAMHSA, where they were able to initiate Suboxone in the emergency room with follow-up by a provider within 3 days. In Yavapai County, we have I believe one methadone clinic, but then we have multiple Suboxone providers. One thing that we just began here at Spectrum is mobile medication assisted treatment. So we have moved our MAP program for opiate use disorders into, it's a literal like RV doctor's office, and it drives around the community to ensure access to care. And that is we're I think the first of our kind to do that. So it's a very unique program to have Matt on wheels going around serving our different communities in Arizona. But it's all about partnerships and referral sources, because obviously we don't have Suboxone or methadone on scene on calls either. It's that referral and that system of care that we've really talked about in that collaboration. We've really talked about knowing where to refer. So Beya's team is looking at that at release from the jail and evaluating opiate use disorders within the jail and making sure that they have release to treatment that provides those services.
Deirdre, are you able to connect these questions with email addresses and help us collect all the other questions that we haven't gotten to? And then Paige and Tamara and Brent and I can kind of
I
work on
believe
emailing.
so. So the registration list does include the email address. So I can double check that, but also folks can email me their questions and I can kind of send them back out. But as of right now, I still have in the Zoom account every registrant's email address.
Okay. We have 2 minutes. Do you want us to keep on going? I'm coming back to you.
I mean, it's 1 minute now, so unless they're pressing, someone wants to take themselves off mute and shout out their question in the next 60 seconds, I think we'll probably end it here. I'll put my email address in the chat for everyone again as well, but I just really wanted to say thank you so much to the panelists. I really appreciate you being here today and talking about the work that you're doing in Arizona. And really for facilitating such a great discussion. Obviously, we probably could have kept going if there had been more time. So thank you again for taking time out of your day to do this. And a reminder that the session recording will be available on CSG's website next week, should be by next week. Thank you all so much and have a great afternoon.
Thank you.
Thank you, everyone.